We'll start with the general appearance and vital signs portions of the physical exam. When you start any physical exam, you begin that by taking a general look at your patient. What information do you get from that? Lots of information. Does this person look sick or well? Does this person look younger than or older than their stated age? Are there postural issues, obvious skin issues? If you pay attention to those kind of things, you'll quickly make that a very important part of your assessment of the patient. So you'll always start with a general appearance look, and that's the very first segment of your physical exam. The next thing, you'll move on to are the vital signs. And you start vital signs with pulse and respirations. The key here is not to mention the fact that you're measuring respirations to the patient, because as soon as you tell someone that you're going to be watching them breathe, their respiratory rate will change. So you'll start by taking their pulse. The patient can lay their arm comfortably in their lap, and you'll be placing your fingers over their radial pulse. Remember, that's on the thumb side of the hand. And you'll take this pulse for between 15 and 30 seconds, depending on its regularity and how easy a time you're having getting the information that you need. After about 15 to 30 seconds of taking the pulse, you'll look for the patient's respirations without signaling that to them. You can look at their chest and see the rise and fall of their gown. If you're having trouble seeing the rise and fall of their gown, you can place your hand on their shoulders. Sometimes you can feel the rise and fall of their respirations. But either way, the patient will think you're taking their pulse. You'll be taking their respiration for that second 30 seconds. So you'll have your watch out. You'll be looking at it. Get the pulse. This requires some math ability. You have to count for 15 seconds and then multiply in your head. And then you'll be sneaking looks at the patient's gown and counting respiratory rate. And this needs to be done for about 30 seconds because respiratory rate is slower. You're not going to get a good enough sample of respiratory rate in 15 seconds. Once that's done, you'll move on to taking the blood pressure. New blood pressure cuffs are stiff and hard to work with. It's going to take some practice to get the materials and the valves unstuck and working well for you, so you need to spend some time with your blood pressure cuff. Before you use a blood pressure cuff on a patient, you want to always assess whether or not the size is appropriate for the patient's arm. The dimensions that you're concerned with are the width and length of the bladder. And the bladder is that portion of the cuff that inflates when you pump on the bulb. Here's your width, and you can feel it inside the cuff, and here's your length. Ideally, you want that width to be about 40% of the patient's arm circumference, and this is, I would say, barely 40%. And you want that length to be about 80%, and I would say we're close to it. So this cuff is probably barely big enough for this patient's arm. You may not have the luxury of changing cuffs and having a bigger cuff or a smaller cuff, but at least you'll be aware that you may be making an error in the blood pressure reading because of the cuff size. The other thing that students forget, but that is very important, is you need to have your patient's arm at their heart level. Now, when I'm standing like this next to most patients, that's going to be with their arm cradled in my arm. If this patient was sitting and there was a table that we had to use, you may well be able to rest their hand on that table. But for your purposes and how you're going to be taking vital signs, you're going to be resting the patient's arm in your arm. I suggest you do not do that, which is hang the patient's arm under your arm. This can be uncomfortable for the patient. It's hard for them to relax their arm, and it also, if you've got a male patient and a female physician, you've got their hand in a potentially precarious position. So it's better if you've got their arm cradled outside like this. You can also do it on the other side if that's more comfortable for you, and you're going to have to practice and figure out what's more comfortable for you. But you do want it cradled so that it can be relaxed, so that it's approximately, the wrist is approximately at the patient's heart level, and that you're comfortable and can sort of maneuver with your equipment. So this is what I'm going to suggest. You need to find the patient's brachial pulse, which is usually medial to the biceps tendon. And once you feel that pulse, you know where to center your cuff. Then you'll take your cuff, ask your patient patient to kind of turn their arm for you so that you can center that cuff over that brachial pulse. Okay, not quite tight enough, so let's try it again. This is trickier than it looks. You will struggle with this, and that's okay. By the time you're done, you'll have it down. The first thing that you're going to do is take the palpatory blood pressure. You can go ahead and relax that arm. There you go. You're going to take the blood pressure by feeling the radial pulse. You're doing this to establish the true systolic blood pressure and to avoid missing an auscultatory gap. For the definition of an auscultatory gap, go to lecture or ask your small group instructor. But anyway, you're going to put your fingers on the radial pulse again and pump the cup up until you can't feel the pulse, and then about 30 millimeters of mercury higher. Then you're going to slowly let air out of the cuff until you feel that pulse again. And feel it at about 118, and then you can quickly let air out. That's the true systolic. You'll expect to hear the systolic or carotid cuff sound 1 at about 118. Now have your patient kind of shake their arm out, because if you get blood pooling after multiple attempts at taking a blood pressure, you can muffle the sounds. After you've done that, you're ready to do the auscultatory blood pressure. To do that, you got to put your stethoscope on. Support your patient's arm at their heart level. Get your stethoscope positioned over the brachial artery, and then pump the sphygmomanometer up until you get to about 30 millimeters of mercury over that systolic or palpatory systolic. And slowly let the air out all the way down to 0, listening for the carotid cuff sounds. Now that slow release of the air all the way to 0 is different in the auscultatory blood pressure than it is in the palpatory blood pressure. When you're doing the palpatory blood pressure, you're simply trying to get the systolic reading. And so you hear that, or you feel that, and you let it out. When you're doing the auscultatory blood pressure, you want to listen all the way down to 0, because in some adults, you will hear sounds all the way to 0. This is indicative of certain cardiovascular diseases, and so you want to be in the habit of looking for that every time you take